Okay. Well, thank you, Weaver. Good to see you. Good to see all of you guys, and thank you very much for the opportunity to come and talk to you. I have to say I'm a little bit humbled and surprised that I get to give this talk today about new directions, but I have been involved in this space for a little over 30 years, I think now, and I reflect back onto the early days of change and how we are getting to where we are. I started being involved in the field of pain medicine, started the division of pain medicine at Johns Hopkins in the Department of Anesthesia back in the very early 1990s. And at that time, the field of pain in particular, which is a big area for a lot of us, was very much behaviorally oriented. It wasn't where we are today, thinking about the complex interplay of science and electronics and disease, which is where we are today. And I've had a career path that's kind of taken me down a few areas that have been somewhat relevant, I think. In 2001, I was president of NANS. And when I was president of NANS, we were just another pain society. We were spinal cord stimulation for pain, but maybe a little bit of implantable pumps for spasticity. And the vision that I had at that time for us was that we were going to become a platform society to try to study diseases where neuromodulation could have a role. Instrumental in that was the work Bob Foreman was doing, looking at cardiac perfusion and what we were seeing with cardiac perfusion with high electrical or high thoracic spinal cord stimulation to improve cardiac disease, peripheral vascular disease. There was work going on in artificial vision and artificial hearing, and we changed the construct of the board to really be a platform for various groups to talk to each other. And bioelectric medicine, I think, has really put that on steroids, so to speak, really improving the ability to communicate and talk about various diseases. On a macro level, when I stop and I think about where we are, I think about the evolution of our field. And I have this picture up here of Thomas Kuhn. And I don't know if anybody knows Thomas Kuhn, anybody in the room like a geek like me? Nope, just one. So Thomas Kuhn was a philosopher of science, and he reflected back on the history of science and how science makes a change. And I think of that we're in the midst of this evolution that he talks about. And he talks about the history of electrical research in the first half of the 18th century provides a more concrete and better known example of the way science develops before its first universally accepted paradigm. During that time period, there were almost as many views about the nature of electricity as there were important electrical experimenters. He goes on to say, history suggests that the road to a firm research consensus is extraordinarily arduous. And as I read that, I thought a little bit about our field and where we are today, in that as we are advancing what we need to do to use electricity to modify disease, this is a difficult path that we're all going down. It's not, oh yeah, this makes perfect sense. Let's go down this path and everybody's going to start to adopt it. That's just not how it works. And I would say that medicine is now in that paradigm shift that he talks about in the evolution of science. And people have suggested that before the 1950s, it was all a study of the placebo effect and there wasn't much going on. But the 60s brought us medications, and that really revolutionized a lot of things, probably took us from a life expectancy in the 30s to in the 70s. We had behavioral orientations come out in the 50s and 60s that really kind of took over to a large degree. And then minimally invasive approaches have started to come forth. The last two bullet points here, I think, are still in the evolution. It's bioelectric medicine and neuromodulation and regenerative medicine. Now, bioelectric medicine, I think, is really ready. It's really ready for prime time. Regenerative medicine shows great promise, but we're not quite there yet. And I think as we start to think about where we're going, we need to think about globally the fields and where we're going to go. And bioelectric medicine, I think, is really important. Within a large operation of thinking about paradigm shifts, I think about spinal cord stimulation. When I was getting started, it was unheard of for an anesthesiologist to implant spinal cord stimulator. Well, not unheard of, but I was the first academic anesthesiologist to put in a spinal cord stimulator. It was not universally accepted that we should be able to do this. And over time, spinal cord stimulation for pain has really robustly increased in its level of embracement in the medical community. 110,000 implants last year with spinal cord stimulators. And when I got started, it was Medtronic and a small company called Quest, which was then became ANS, which then became St. Jude, which then became Abbott, and it became a big company. But over time, instead of having one company involved with very simple concepts of, I shouldn't say simple because it's disrespectful to Ron Melzak and Pat Wall, but the idea was that if we stimulate the spinal cord, we can turn off the small fibers of pain, and we could just get rid of pain by closing the gate, as he said. And what we learned is that's probably a little bit simplistic for what's going on. On the right side of the screen, you see that I talk about a paradigm shift. Nevro came out with high frequency stimulation that didn't fit into any of these frameworks. Medtronic is now relooking at things with DTM, the diffuse targeted multiplex, which is thought to modulate the glial cells in specific personalized approaches. Biotronic is coming out. And as I very briefly look at this, I think that there are 9 companies that are either right here, ready to go, or actually selling product today in the United States and abroad. And then another aspect that's happening is neuromodulation is moving its way from being a very end of the road therapy to being a more middle of the road therapy. So we're able to do these therapies earlier in the course of the disease process. Now, my personal interest kind of started to meld with my academic interest. And you see peanuts up here on the screen here. And I became interested in thinking about what Bob Foreman was doing with modulating cardiac perfusion and peripheral vascular disease when my son had peanut allergies. And I went down the road of trying to say, okay, what else can we do if you have an anaphylactic reaction? You shut down the airways. What can you do? And you think about it, what is there? There's epinephrine, there's steroids, there's cromolyn sodium, but it can be a very life-threatening disorder for kids. And I was an anesthesiologist and recognized that if you take a child who's got an asthma problem to the operating room and they get anxious, they can have an acute asthmatic reaction. That's something that's kind of well known out there. And the idea was, well, if there is and nobody really stopped to think about it at the time, well, why would that be? There's got to be some connection between the brain and the lungs doing something, was the idea. And we went to the lab in Columbia, right here, with a guy that I had used to work with at Hopkins, and we did some initial guinea pig work. And we took these little guinea pigs and we gave them histamine to cause their airways to collapse. And we showed that up on the top left corner here, that you could blunt that from happening by stimulating the vagus nerve. Now, it's not really relevant why we did this and all that, but our hypothesis was entirely wrong about why this worked, and it turns out that it was something else. But as we continued to work on this, we developed a percutaneous approach where we could place an electrode on the vagus nerve in about 6 minutes. And we trained ER docs to be able to do it relatively quickly. So if someone's coming in with status asthmaticus, they could get a vagus nerve percutaneously applied, and potentially down the road that might become an implant for someone with peanut allergies or status asthmaticus. And on the far left here, you see, bottom left here, you see AlphaCore. And AlphaCore was developed by a non-invasive approach to using vagus nerve stimulation for airway reactivity. And that was developed by Bruce Simon and J.P. Errico to come up with a non-invasive approach to doing the same thing that we were doing invasively. And while we were studying that, somebody said, my headache went away. And that was one of the first times that I started to read about Jakob's work and other people's work about all of the other things that the vagus nerve does. I was really focused on, okay, brain, lung, not all of the other stuff that's out there. And we started to really think about where we are today as the vagus nerve being so critically important in multiple medical disorders and multiple diseases, and that it can control cardiac, pulmonary, hepatic regulation, splenic regulation, as the set point team is working on, gastrointestinal problems, brain modulation, and we've got work going on in PTSD, opioid use disorder, anxiety, depression, Parkinson's disease, all through similar pathways. And one of the challenges we face, I think, as a field, is that when we say, I can solve all of these different disorders, people look at us like snake oil salesmen from the 1950s, or 1850s, I should say, snake oil salesmen. And we have to stop and say that we do a few things well. We modulate inflammation, we modulate a few neurotransmitters well when we are stimulating various structures in the body. And these have long-term effects, and inflammation can have effect on neurologic disorders, pulmonary disease, cardiovascular, and you see the list here. And these are areas of acute study going on right now or in recent past on the afferent pathway and the efferent pathway of the vagus nerve. And I think that's an oversimplification the more I get into this, but I do think it's an easy way to break this up on structures inside of the brain and structures outside of the brain. And the vagus nerve, as among other areas, control a lot of different functions in the body. A second point that I think is worthwhile bringing up is that the use of electricity is not unique to bioelectronic medicine or neuromodulation. While I remember very clearly when I was doing work on COVID and I would talk to the immunologists, they looked at me like I had two heads. You mean you tell me that you're going to stimulate the vagus nerve and you're going to turn off inflammation? No way, not interested. We're not going to do any studies on this. And it's an important challenge for us to say, well, if you have end-stage epilepsy, brain's been resected, and you failed all medicines, what do you get? You get an implanted vagus nerve stimulator. If you've got bradycardia or you got arrhythmia, what do you get? You get a pacemaker. Spinal cord stimulation is the best thing we have for back pain. And we go down the list and we can show that electricity can be a really effective therapy for a lot of different disorders. And I think that's helpful to a lot of different organizations. And just to reframe us as a biochemical organ system. We're not just a bunch of drugs, but we are drugs and electricity together in how we function. And we have spent an inordinate amount of time talking about drugs and not enough time talking about the electrical side of things. And this field is where I think science meets the future, meets technology, meets medicine. And I think we have to throw in here, I didn't actually think about it right now, reimbursement strategies, because it is a huge challenge for a lot of us on the reimbursement side. And I see a lot of very senior people here, but just kind of a way of thinking about this and getting started is, what's your unmet medical need? How are we going to solve this use of electricity? What's your competitive advantage that you see today? Are your ideas protectable, or is a big Medtronic going to come in and just take over from you? Define your indications carefully. Decide what studies need to be performed. Very early on, very carefully think about your path to reimbursement. Think about insurances will cover it and whether or not they're set up to cover these types of therapies. As the regulatory pathway for a lot of the non-invasive stuff is just not really clear. And then what's the path for going to market? Are you going to go down existing codes? You have to think about how doctors are going to get paid, to align incentives for people. Are you going to go down a pharma pathway that Jim just spoke about, or are you going to go down the traditional medical device pathway? Transparently, I thought the pharma pathway made perfect sense. You can come up with a much lower cost therapy that only you utilize if it's helping, like a drug. But a lot of the reimbursement pathways just were not set up to do that. And that makes things quite challenging. And so you need to think through pharma, medical device, traditional pathway. At this meeting, people talked about a DTC approach and how we're going to do that. How do we integrate with evolving technology? And I also think this, I've started to think about the valley of death for small companies. Does anybody know the term valley of death? Valley of death is something widely accepted in the broader industry, not as well established in our field. So I'm pleased that you all say that. But in the broader field, you start with research and then you develop a product and you have to commercialize it. And there's a time period before you can actually become profitable. I think about valley of death for us as, okay, you're increasing your evaluation. You've got FDA clearance. But until you start selling, hey, Chad, you start going down into this valley of death until you really establish reimbursement. And that is a challenge that a lot of us will face or have faced over time. And this is only getting a little bit more difficult with the financial downturn, increasing reimbursement requirements of insurance companies. They're becoming a lot more stringent on what they'll cover. There's increasing regulatory requirements. It's important that to understand that the industry is somewhat consolidating in some areas, and there are forces that don't want us to succeed. Some of the pharma forces that don't want us to succeed. And with that, there has become decreased venture capital investment that we see.
Dr. Staats, there's also societies that don't want you to succeed, right? The surgeons.
The surgeons don't want you to succeed, and that's actually a really good point. Brings me to this next slide, and I have the opportunity on behalf of a number of different companies, including electroCore, to speak with big insurance companies. And early on, in New York City, we hear an alarm, we start to get worried there.
That's the alarm that says just a couple more minutes.
Okay, I'm 2 more minutes. I hope the plane's not flying at me right now. Okay, but you know, it started off with, you just need to show that your therapy works. Then it moved to double-blinded randomized controlled trials. Then it moved to, you need big data. Then it moved to, well, you've got data, but are you cost dominant? Do you provide better care at a lower cost? Then it's moved to your point, you have clinical societies that are supporting and advocating for you and trying to help you succeed. And you know, sometimes you need market access people to go in and talk to people. So this pathway is becoming a bigger portion of should be a bigger portion of your brain power as you're evolving your field of how we're going to get to market and get insurance by whatever pathway. To the point is, we did get Health and Human Services. Vanilla Singh's group embraced non-invasive vagus nerve stimulation for cluster and migraine in their alternative to opioids, tapping into the concept that there's too many opioids being used, and we need alternative strategies like neuromodulation or bioelectric medicine strategies. And I'll conclude with change is hard. This is difficult for a lot of, we're all deep inside of this and we can see what we wanted to see, but for other people to come in and embrace this, it's very difficult for others to see this. And there are other forces going on, miniaturization, non-invasive versus surgical, or earlier use of neuromodulation, I think is going to be something you'll see. You need to think through remote monitoring, tapping into the existing codes, and are there opportunities there? Personalized medicine, I personally think, will be an important aspect of where we roll in the next generation of neuromodulation therapies and bioelectric medicine. And I'm going to end with this kind of concept here is we spend, and my DNA was implanting these devices. We spend a lot of time thinking about the next generation of device that really is extraordinarily effective for a very small population. And as we're advancing in our field of bioelectric medicine, it's going to be important that we expand that out to being percutaneously applied. Some novel therapeutics kind of coming into that middle ground of saying it's not a full implant, but it's kind of an implant. And then I think at the very basis, if we can really embrace non-invasive approaches, we're going to be able to access a lot more people who could potentially benefit this across the bioelectric medicine space. So in conclusion, I thank you very much for listening intently and listening to me. And again, I'm pretty humbled, James and Jojo and Jeremy, thank you for the invitation to come. I think that the medical community is in the midst of this paradigm shift. We're right there. It's hard to see it when you're right in the middle of it, but I think it's happening. That's exciting. I think our therapies are extraordinarily effective. We are expanding our armamentarium into new diseases every day that are really have a high unmet medical need. But the challenges remain with reimbursement strategies keeping up with us. But my concluding thought is they'll get there because we are effective, we are cost dominant, and there is a real desire to embrace this type of approach for chronic diseases. So, thank you very much.
Peter, thank you very much.
Thank you, Dr. Chair.